about all of the hates medicosis perfectionalis, where medicine makes perfect sense. Let's continue our biochemistry playlist. In previous videos, we have talked about all of the vitamins. Today, it's time for vitamin B9, which is known as folate. With that said, now let's get started. Vitamin B1 is thiamine, B2 is riboflavin, B3 is niacin, B5 is pantothenic acid, B6 pyridoxine, B7 biotin, B9 folate, B12 is cobalamin. This is way more organized than this. Is folate the same as folic acid? Technically, no. Clinically, I don't care. So if you look here, they said folate 680 micrograms, and then for the nerds, they added 400 micrograms of folic acid. Folate or folic acid has bazillion names. Folate, folic acid, vitamin B9. The old names include vitamin M and vitamin BC, tyrol glutamic acid, fermentation residue factor, and even Streptococcus lactis R. Just remember the first three. No one gives a rip about the others, but if your purpose is to flex your academic muscle on your professor, then by all means go ahead. In my video on vitamin B5, I've told you that pantothenic acid is different from pantothenate. They are different in chemistry. Pantothenate is the anion form of pantothenic acid. Same story about pyruvate and pyruvic acid, folate and folic acid. We can use them interchangeably, but technically, they are not the same. Someone asked the following question to Professor Bruce Nathan Ames, a professor of biochemistry and molecular biology emeritus at the University of California, Berkeley. The question is, Professor, do you see any difference between taking vitamins or minerals through pills versus getting it naturally in food? Professor Ames, who is one of the most cited scientists in all fields, just wrap your head around this stuff, answered, I think it's pretty much the same thing. There are few little differences. Example, the folic acid that you get in a pill is not the right folic acid. It's an oxidized form. But little things like this eventually get ironed out. This was from an old recording. Since then, I'm aware of 3 studies comparing folate and folic acid. So hey medicosis, is taking folic acid in a pill dangerous? As Dr. Jordan Peterson might say, well, it's complicated. It's not simple. It's not. More on that later. Vitamins, it's a wrong name. We thought they were vital amines, but they're not. Organic molecules, micronutrients, they are essential. You have to eat them in the diet. And we have 2 types, water-soluble and fat-soluble. Water-soluble, B and C. Fat-solubles, vitamin K, E, D, and A. Water-soluble vitamins include B and C, which includes B9, which is folate. Not stored, with 2 exceptions. Vitamin B9 or folate is stored for 3 to 4 months. Vitamin B12 is stored for 3 to 4 years. If you are a water-soluble vitamins, deficiency is more likely, toxicity is less likely. If you don't believe me, go to any hospital, ask any doctor, hey doctor, have you ever seen hypervitaminosis B9 or folate intoxication? What are you talking about? Hey son, I've been in this profession for 35 years and I've never seen anything like it. Vitamin Bs, or the B complex, B1, thiamine, B2, riboflavin, you know the rest of the story, right? Medicosis biotips. Vitamin B1 is good for decarboxylation reaction. The enzyme is a dehydrogenase, usually. B2 is for reduction oxidation. B3, reduction oxidation. B5 is for CoA. Whenever you see that CoA, you can thank your pantothenic acid. B6 or pyroxene for transamination, for the transaminases including ALT and AST, known as the liver transaminases. B7 is for carboxylation. B9 folate is for transfer of 1 carbon unit, just 1 carbon. Vitamin B9 or folate sources, we have natural sources, artificial. Let's start with the natural, which means food. We have good sources and we have fair sources. Good sources, green leafy vegetables, man, especially spinach and cauliflower. Also, organ meat, such as liver and kidney, yeast, meat, and fish. Fair sources include fruits and milk. Artificial sources of vitamin B9 or folate, enriched food, and folic acid supplements, usually oral. Functions of B9, which is folate, transfer of 1 carbon unit, just 1 carbon. And look at these, yep, 1 carbon. The 1 carbon could be in form of a methyl group, a formal group, a formate group, a formamino group, and a hydroxy methyl group. Who named these things? We need folate in order to make DNA, and we make DNA in order to replicate the cell. If your cells do not replicate, you'll simply die. Okay, medicosis, I ate some green leafy vegetables. Where does the folate get absorbed? It gets absorbed in the jejunum. Okay, how can I remember this? Here's a great mnemonic from Dr. Ellie. Here is your anatomical order. Duodenum is first, then you get the jejunum, and then the ileum, right? Right. And this is the laundry order. First you iron your clothes, then you fold them, then you put them in the closet. So duodenum is iron, then jejunum is folate, fold them, and then you put it in the closet, which is cobalamin at the terminal ileum. This is genius. So folate, just remember 2 J's. Absorption, jejunum, enzyme needed, conjugase. What the flip is a conjugase? Now let me tell you. Here are the folate forms. We have monoglutamate, triglutamate, and heptaglutamate. Mono means 1, tri means 3, hepta means 7, octa is 8. So why is 3 types? Based on what? Based on the number of glutamic acid residue, as you see. And these glutamic acid residues are attached to pteroic acid, also known as pteridine PABA complex, para-aminobenzoic acid, and we'll talk about that soon because sulfonamides are antifolate. All of these things are less water-soluble and poorly absorbed. That's the problem. What's the solution to this problem? Conjugase, found at your jejunum. This will help liberate the pteroglutamic acid. Awesome. I ate my green leafy vegetables to make my mama happy. Good for me. And then the conjugase will liberate them. And then here is the folate. What's the active form of folate? THF. Before THF, you have methyl THF. It's CH3. THF has to get rid of the methyl group. Okay, it will dump the methyl group onto B12. B12 now is called methylcobalamin. Methylcobalamin will say, oh, why did you dump the methyl group on me? I hate it. I am gonna dump it on homocysteine. B12 will dump it onto homocysteine. Homocysteine will become methionine. Methionine will give you Uncle Sam, and Sam is a great methyl donor. Where did it get the methyl from? From here, baby. From here. Think. Now, THA, that's the active folate, man. And then it becomes 5 and 10 methylene THF, or 5 and 10 dimethyl THF, and then DHF, and then back to THF. Who converts the DHF, which is not so active, into THF, which is very active? The doozy enzyme known as DHF reductase, dihydrofolate reductase. Now I have THF. THF is very important because it will convert DUMP into DTMP, and DTMP will help me make DNA. THF is cool. Why? Because it's a 1-carbon donor, converting DUMP into DTMP. The difference between them is 1 carbon. Purine synthesis, which will make you DNA. DNA will make RNA. RNA will make proteins. Proteins are made of amino acids. Let's add some pharmacology, baby. Phenytoin inhibits conjugase. That's why it causes folate deficiency and folate deficiency anemia, which is a megaloblastic anemia. Alcohol and oral contraceptive pills inhibit folate absorption. Methotrexate and trimethoprim inhibit dihydrofolate reductase, causing folate deficiency. How do I replenish it? It's called leucovorin rescue or folinic acid rescue to replenish 5 and 10 dimethyl THF. Famous exam question. Next, 5-FU, 5-fluorouracil. FU back. It inhibits the conversion of DUMP into DTMP. Who stores folate? The liver. What can I do with THF? Lots of things, including 2 very important things. Number 1, convert DUMP into TMP and then make some DNA. Wonderful. Also, the THF will become FTHF. F is for formyl. This will help you with the de novo purine synthesis. And you need purines in DNA and RNA. Folate, green leafy vegetables, then becomes dihydrofolate, and then becomes tetrahydrofolate, which is the most active thing. How do I become dihydrofolate? When I add hydro, which is hydrogen, that's a reduction. Adding oxygen is an oxidation. Adding hydrogen is a reduction. This reductase needs vitamin C as a cofactor, and here is an example of a vitamin that needs another vitamin to be active. THF will become 5 and 10 dimethyl THF, and then by the enzyme called methylene tetrahydrofolate reductase becomes 5-MTHF. We have a methyl group. Dump it on B12, which will dump it on homocysteine to become methionine. Methionine will become SAM. SAM is a methyl donor. THF, DUMP, DTMP, DNA. Excellent. THF will also give you purines. Wonderful. The active form of folate is THF. Remember that THF will transfer a 1-carbon unit. Benefits of vitamin B9, direct and indirect benefits. Direct benefits, basically when you give vitamin folate, which is B9, it's oral. Most of the time, you need a prescription before an injected folate. This is getting serious. When I give you folate, I can help treat your folate deficiency. I can help prevent neural tube defects. Biochemically speaking, transfer of one carbon unit, such as CH3, that's the methyl group, that's a one carbon, so methylation. DMP into DTMP, that's a one carbon unit. Glycine, serine, the difference between them is one carbon unit. Homocysteine into methionine, the difference is one carbon unit. And purine synthesis. Here is your homocysteine. Homocysteine has two choices. It can become cystathionine, thanks to B6 and cystathionine synthase, or it can become methionine, thanks to vitamin B12. For me to go from homocysteine to methionine, I need to dump my methyl group from the folate into the B12. B12 will dump it onto homocysteine to become methionine. Imagine that I have folate deficiency. No methyl THF, and of course no THF. Therefore, homocysteine will not become methionine. What will happen to homocysteine level in the blood? It will increase, called homocystinemia or homocystinuria. Complications include, are you ready? Heart attacks, strokes, intellectual disability, formerly mental retardation, aortic wall rupture, atherosclerosis, deep vein thrombosis, joint contractures, and lens subluxation. And the lens subluxation in homocystinemia is downwards and inwards. But in Marfan syndrome, the lens dislocation or subluxation is outwards and upwards. How do I remember it? Draw a kidney. This is homocystinemia or homocystinuria. Look at the ureter. It's going this way. This is downwards and inwards. But write Marfan syndrome. Look at the F. Marfan is outwards and upwards. This mnemonic is from Dr. John Baroon at baroonrocks.com. Okay, cool. Let's say I have vitamin B12 deficiency. What will happen to homocysteine? It will increase, leading to homocystinemia, which is horrible. Let's say I have vitamin B6 deficiency. Also, homocystinemia can happen. Let's make it more complicated. Here is homocysteine can become methionine. And of course, methyl group, dump it onto the B12, dump it onto homocysteine to become methionine. What's the difference between these two? One carbon unit. Basically, methionine has a methyl group that homocysteine does not. Where did it get the methyl group from? From the B12, which got from the folate. And that's why folate is a one carbon donor. A transfer of one carbon unit. In this case, it was the methyl group. That's why Sam is a great methyl group donor. And here is Uncle Sam, a great methyl group donor. But he will take all of your money, your methionine. The other pathway, cystathionine synthase. To make cystathionine, we need B6, and then cystathionine will become alpha ketobutyrate, which will become propionyl-CoA, and then by propionyl-CoA carboxylase. Remember, whenever there is a carboxylase, there is always B7 or biotin. Then you have methylmalonyl-CoA. Methylmalonyl-CoA will give you succinyl-CoA. You can thank vitamin B12. Succinyl-CoA is super cool. You can use it in the TCA cycle. You can use it to make new glucose called gluconeogenesis, or you can use it to make heme called the heme synthesis pathway. And I have a video about heme synthesis on my channel. Folate deficiency. We have talked about this before in a previous video, so we'll do it very quickly. Folate deficiency will lead to a macrocytic anemia. MCV is greater than 100 femto liters, and the cell is huge. Macrocytic anemia could be megaloblastic or non-megaloblastic. Megaloblastic, why? Folate deficiency or B12 deficiency. Non-megaloblastic, why? Liver disease, alcohol, or drugs. What is the main difference between these two? Megaloblastic has hypersegmented neutrophils, but non-megaloblastic does not. Macrocytic anemia could be megaloblastic or non-megaloblastic. Why megaloblastic? Due to defected DNA synthesis. Why non-megaloblastic? Due to liver disease or alcohol, which can trash your liver, etc. What would you see in megaloblastic? The name has the answer. I would see blasts. No kidding. What would you see in liver disease or non-megaloblastic macrocytic anemia? You will see target cells. After all, target is a superstore. It's macro. Tell me more about what you mean by blasts. I mean big cells, giant erythroblasts, giant myeloblasts with hypersegmented neutrophils, and giant hypersegmented megakaryocytes that may lead to giant platelets. Why is this? Because remember, Hematopoiesis involves making new cells. When the cells are immature and young and naive, they are like this, big and huge. When they mature, they get smaller in size. In order for the cell to replicate from this stage to this stage, two things have to happen. Number one, I need to replicate the cytoplasm. This is easy. Two, I need to replicate my nucleus. That's not easy because this needs folate and B12. Okay, so this cell was starting to divide, right? Number one, let's divide the cytoplasm. Easy, I will divide the cytoplasm for you because I am ready to make two new cells. So I divided my cytoplasm. But I was waiting for the folate. The folate never came because the patient had folate deficiency. Now the cell will remain like this with double-sized cytoplasm, but just one nucleus. And that's a blast. That's a macrocyte, a big, huge, immature, ugly red blood cell. You get a macroovalocyte, a giant metamyelocyte, and a giant megakaryocyte. This is amazing. I mean, it's terrible. Folate deficiency causes its economics. It's either decreased supply or increased demand. Decreased supply, malnutrition. Don't forget, your liver can store folate for 3 to 4 months. So if you say, hey doctor, I've tried this new diet based on the suggestion of an online blogger for 7 days. And then 7 days into the diet, I suffer from severe folate deficiency. Look here, my friend, as much as I dislike these online bloggers, you are a lying SOB, which stands for shorts of breath because I'm a good doctor, I do not curse. Your folate deficiency is not because you changed your diet 7 days ago. You're probably an alcoholic or you take some medications. That's way more likely than blaming the online blogger. Fool me once, shame on me. Fool me twice, shame on your folate. Increased demand, of course, happens in pregnancy because now mommy has to support herself and her baby. Don't forget to give mommy lots of folate even before she gets pregnant to decrease the risk of neural tube defects. Causes of folate deficiency: decreased intake. This is malnutrition, happens in infants, elderly, and alcoholic. Increased demand happens in pregnancy. Malabsorption syndrome such as celiac disease. Drug inhibition: 5-FU, TMP, SMX, methotrexate, phenytoin. Alcohol and oral contraceptives can inhibit folate and cause folate deficiency and megaloblastic anemia. Increased utilization happens in pregnancy, lactation, malignancy, hemolysis. Folate antagonists, let's talk pharmacology, baby. Why do you use them? We use them for cancer. Do you know why? Yeah, because cancer cells are dividing like crazy. Let's actually prevent their division by depleting their folate so that the cancer cells cannot replicate. Wonderful. Example, methotrexate. How about immunological diseases such as rheumatoid arthritis or inflammatory bowel disease, whether it's ulcerative colitis or Crohn's? You can give sulfasalazine. Why is this? They inhibit the rapidly dividing cells. In this case, these are the lymphocytes, including the B lymphocytes, that can secrete autoantibodies, and autoantibodies cause autoimmune disease. Next, infections. Let's deprive the bacteria from folate so that it cannot replicate. Case in point, trimethoprim sulfamethoxazole. Antifungals. Let's inhibit the replication by 5-FU back, which is 5-fluorouracil. Parasitic infections. Let's stop it by pyrimethamine sulfadiazine. Everything that starts with a sulfa is a sulfa drug. Therefore, do not give it if the patient is allergic to sulfa or if a patient has the most common enzymatic deficiency worldwide, which is G6PD deficiency. Also, please pay attention. This is called sulfasalazine, but this is pyrimethamine sulfadiazine if you want to flex on your pharmacology professor. Let's talk about sulfonamides and trimethoprim or pyrimethamine. This is a folate pathway. We start, remember, I've told you PABA is important, para-aminobenzoic acid, plus pteride. And then you give you dihydroteroic acid, then dihydrofolate, which is DHF. That's not the most active. The most active is THF. What's the name of this doozy enzyme? Dihydrofolate reductase. Then you have the methylene THF, and then you get the purines, the thymidine, which is pyrimidine, and then the methionine, which will give you Uncle Sam, which is a great methyl donor. Sulfonamides inhibit the first step. Trimethoprim or pyrimethamine inhibit the second step. And that's why the doctor may prescribe TMP, SMX together. That's the trimethoprim and the sulfonamide, which is the sulfamethoxazole. When you block this and block this, folate is history. We call this sequential block in pharmacology. Now, folate is history. I have good news and bad news. Good news, your bacteria will not be able to replicate. Go to hell. Bad news, you will not be able to replicate your cells on your bone marrow and you'll get anemia, thrombocytopenia, or leukopenia. Okay, let's say it's not bacteria, it's a parasite, which is toxoplasmosis. We give pyrimethamine sulfadiazine to achieve the same sequential block. Signs and symptoms of folate deficiency. If you have low folate, there is decreased cell division, which will lead to pancytopenia because your bone marrow cannot make red blood cells, white blood cells, and platelets, leading to anemia, leukopenia, thrombocytopenia, which will lead to tired and pale, infections, and bleeding respectively. Also, if my cells are not dividing, I'll get glossitis, and neural tube defects are more likely when I have folate deficiency in case of pregnant women. Anemia can lead to tired and pale, pale and tired. Sometimes I have angina. Sometimes I can get a murmur. The murmur is a flow murmur. Always systolic, never diastolic. I can also get headache, dyspnea, dizziness, exercise intolerance, and even hyperdynamic circulation. Question: why does anemia cause hyperdynamic circulation? I'll tell you why. Because anemia, you have less red blood cells. Oh, if I have less blood cells, at least I can compensate by making them flow faster so that they can carry oxygen to the tissue. Your body is way smarter than all of your professors put together. And here are the causes of high output cardiac failure or hyperdynamic circulation. You see, anemia is number one. Everything is fast, everything is dilated, everything is distended, including your jugular vein. And if you are able to diagnose anemia just by looking at the patient's face and at the patient's neck vein, I want you to be my doctor. If you cannot suspect anemia without ordering lab tests, kiss my calcaneus. How do you diagnose folate deficiency? Look at the number, look at the function. Level of folate, just measure the folate in the serum. Function of folate, the FIGLO test. FIGLO stands for N-formamino glutamate. This is FIGLO. Okay, FIGLO can be converted into glutamic acid if you have folate. But if the patient lacks folate, this is not going to happen, which will lead to accumulation of FIGLO in the blood and therefore in the urine. Also, you can diagnose folate deficiency anemia based on the labs and the FIGLO test. Don't forget the macrovalocytes, hypersegmented neutrophils. Sometimes you can get pancytopenia, hyperhomocystinemia, and homocystinuria. There are no neurological symptoms in adult patients with folate deficiency. Of course, there are neurological symptoms if the patient has spina bifida or meningocele or meningomyocele or a neural tube defect. As you know, serum methylmalonic acid is normal in case of folate deficiency, but abnormal in B12 deficiency, and you get neurological symptoms in B12 deficiency, but not in folate deficiency. Treatment: if the patient lacks folate, give the patient folate. No kidding. What's the difference between folate and folic acid? Chemistry, basically. Folate is the natural one, folic acid is the artificial one. Okay, is the artificial one dangerous? So I'm aware of 3 studies. Study number 1, study number 2, and study number 3. Study number 1, no clinical significance. There are no difference between them. How about study number 2? No clinical significance, and there is no difference between the two. Study number 3 said that folic acid increased risk of colorectal cancer. But, however, all of the patients in the study were males, Norwegians, with ischemic heart disease. So if you are a Norwegian male with ischemic heart disease, you should talk to your doctor about your risks and your rewards, should you take folic acid or not. Otherwise, we need more studies. And until they can prove it, I will happily take folic acid. But hey, medicals, aren't you aware that it can increase your risk of colorectal cancer? I will not reply to you. I will let the Charlie do it. To say the detriments without stating the benefits is immature and stupid. Even if it's proven true that folic acid increases the risk of colorectal cancer in the average male in his 20s, I'll stop. But now I take folate because look at the benefits. Vitamins are cofactors for enzymes. Personally, my enzymes are working like a clock. Mommy wants to get pregnant. Even before conception, you should give mommy folic acid until early pregnancy because this is where neurulation happens. All of the development happens around week 4. So this is the crucial period. You need to cover mommy with folate to prevent neural tube defects. If you like this video, you will love my antibiotics course. It has 40 videos that you can download right now. Go to medicosisperfectionalis.com. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my antibiotics course and my other premium courses. Thank you for watching. As always, be safe.